All right. Good morning, everybody. It's so nice to see some people in the audience here. My name is Christina Mangurian. I'm a professor in the Department of Psychiatry here, and I am thrilled to get to introduce Dr. Ayana Jordan here today. For those of you who don't know Dr. Jordan is an addiction psychiatrist and was recently lured to NYU from Yale and is an associate professor in the Department of Psychiatry and Population Health there. She holds the Barbara Wilson Endowed Chair, which is a massive honor and well-deserved honor for somebody that's such an extraordinary scientist as she is. She's also the principal investigator of the Jordan Wellness Collaborative. She initially started her training at Einstein and then did her residency and fellowship at Yale. She has 3 R01s and 2 SAMHSA grants as PI currently. She's really quite extraordinary and has the capacity not only to communicate her science effectively in scholarly places like this, but also within all sorts of different settings and communicate that in ways that people can really understand. And so whether it's on social media, whether it's in the lay press, whether it's on TV, or with her community partners that she works very closely with, she's really quite extraordinary. And I have been friends with Dr. Jordan for many years and have many wonderful memories of her, and I'm just in awe of her. I've been in awe of her and her mind from the moment I met her, and her dedication to health equity and really putting the feet to the ground to help those most vulnerable. And so I'm just delighted to have her here today. I think you all will really enjoy her talk. And that's all. So we'll have some questions afterwards. Please, those on Zoom, please ask your questions on chat, and I'll try to keep an eye on those, and we'll get started. Good morning. I am so happy to be in sunny California. So thank you so much, Dr. Mangurian, for that wonderful introduction. It's good to be amongst friends. That really helps to do the work, make the work much easier. So I appreciate you fully. One of the things that's really important in thinking about conducting research is really how are our findings applicable to actually providing treatment. And so I really want to talk about that, but then learning from all that we have gone through over the past really 5 years, and how can we acknowledge what has happened and take that into the research that we do in taking care of patients. So before I get started, I really do start all of my talks with a land acknowledgement. And I'd like to honor the memory and legacy of San Francisco's original peoples. And if someone can help me with the pronunciation, please do. But I have Olin and Costanoan as defenders and stewards of the land. I do believe it is our duty to acknowledge that many of the institutions where we work, take care of patients, or conduct research on is indeed on native land. So I give thanks to the original people. And then I'll also say that land acknowledgements do not exist in the past tense or historical context. Colonialism, right, really having political control or power over others is a current ongoing process. And we, as researchers, clinicians, physicians, have to be mindful of our present participation. So thinking about how do we participate in oppressive systems in our research and the way that we take care of people is really important to interrogate. I don't have any financial disclosures. I do want to let you know where I receive funding, and I'm not going to discuss any off-label uses of medication. Okay, so really starting off the framing of our talk, my talk here is really to center the Black Lives Matter movement. And the reason why I do this is because I think it's really important to understand that we can't talk about health equity or freedom or access to care or really having a functional mental health system unless we talk about those who are the most kind of victimized. And so I want to center the Black Lives Matter movement, not because I don't think other lives don't matter, but I think that it's really important to understand that until we start treating Black people well, none of us will do well, right? So as an addiction psychiatrist and a physician scientist, I say, stop killing us, right? Literally gutting us down in the street. with needs in our necks, but also figuratively through discriminatory policies. So these are things like overly restrictive methadone regulations, right? Or no knock warrant policies that allow people to be killed, right? Even if there is someone who's not identified. Maybe I can do a quick check on it. And so wanting us to remember. Okay, thank you. So sorry. That's okay. We'll take a pause. I'm fine to pause on Black Lives Matter, so it's all good.
If you want to
hold
it, or
where should this go?
Can be around your ear so that it kind of moves by your jaw bone.
All right. I think that's much better. Yeah. Great. Can you all hear me? That's so much better. Yeah, thank you. Hold your applause until you see whether. Okay, that's so much better. Great. Yeah. No, I'm not stressed. It's all good. Yeah. Are we good to go? Okay, so you guys get it, right? None of us can be into, we're all free if we have to really focus on taking care of those who are the most victimized in order to think about creating health equity. The other thing I want you guys to know is the language that I use. I'm going to say racial and ethnic minoritized people instead of URM, because we know that even in majority minority communities, like places in California, people do not have access to power, right, or decision-making or resources to take care of themselves. So that's a very deliberate use of the term. I will say REM, racial and ethnic minoritized people. So what are the objectives of the lecture? They're really threefold. And I hope that you guys can take away these objectives and thinking about what am I learning from the lecture. One is I want you to identify at least 2 socio-political factors that contribute to the existence of and propagation of substance use, overdose deaths amongst racial and ethnic minoritized people with opioid use disorder and other substance use disorders. We'll talk about some of those other substance use disorders. I want you to recognize at least 3 risk factors that have contributed to worsening addiction disparities among racial and ethnic minoritized populations during COVID-19. And then we'll talk about 2 of the things that we're doing in the Jordan Wellness Collaborative, or JWC, that really offer more culturally acceptable interventions or options for people to have better health outcomes. Before I do that, I do want to set the stage for some framing around how have I really pivoted in the research that I'm doing, considering all that we've gone through since 2020. So in the spirit of Sankofa, this is a symbol of African wisdom and teachings. We must look back to understand how we move forward. And so for the Akan people of Ghana, this is a bird that's pictured here and is usually depicted with its head turned back towards an egg, expressing the importance of reaching back, gaining knowledge from the past to understand how we can make progress in the present day. So for the next few slides, I am going to talk about some really distressing things that we've all collectively went through, but this is the time that you might want to, in the Zoom audience, walk away. If you don't want to hear about death and racism and terrorism, and in the live audience, this is the time to leave. Okay. All right. So really thinking about what are the moments that have really changed the way that I think about conducting research, but also that have really affected us all. And I think we can all agree in really the assassination of George Floyd, May 25th of 2020. I can't believe it's already coming almost on 3 years, but thinking about how we all globally saw the vileness of racism on a very public stage, and how the whole world was watching and saying, what are we going to do and how are we going to react differently? At the same time, we were dealing with extreme isolation, really thinking about how our lives would be forever changed. We were just talking, Dr. State and I earlier, in terms of how COVID-19 has impacted where I live, New York City, and people still haven't recovered. So thinking about the collective psychological duress that has done for people who are already struggling with substance use disorders and made it even more devastating. Thinking about the opioid crisis being in full display, literally thousands of people dying. And I always say that people, just to put it in context, we have lost more people in 2021 alone from the opioid crisis than we did in the height of the HIV crisis, combining 10 years. So really understanding that we are facing a crisis that we've never seen before. Also, the January 6th insurrection. I'll never forget, I had my nephew, who he is my heart, little Lawrence. You'll see him later, but he, in the acknowledgements, he's not coming, although that would be awesome. He's in school, but he stayed with me. He was doing virtual schooling in Connecticut, I was at the time, and he was 10, and he said, Auntie, he had so much emotion, and he said, why do they hate us so much? He said, if those people look like us, they'd all be shot dead, 10 years old. So the reality of what it means to be in a body, and I have a lot of privilege, right? Professor at Yale, all these things, but the reality of what it is to live in a body and know that even in the country, the land of the free, you're not treated the same. And I think having that white supremacy on display, the violence and the range of it all really helped me to understand, like, I have to be able to reach people who are other in another way. I can't just talk about resources or engaging them into what do they need? What are they feeling? Why is the work that I'm doing important to them? Anti-Asian hate, right? Realizing that what we say, what we do, the language we use really does impact how others are treated. And then just the vileness of anti-Black racism, hate on display, the Buffalo killings, the Uvalde killing, earlier this year, the murder of Tyree Nichols, all of these things back to back to back, not really getting a reprieve. And then I'll finally end, and I added this last night because I still cannot shake this. Finally, the shooting of Ralph Yarl. Right? Luckily, he survived, but reality is we all know as mental health professionals, he will never be the same. Never be the same. So why am I spending so much of my time talking about these instances in a lecture for mental health professionals? Because we have to realize that when we're taking care of people in our society, we have to consider how all of these instances have shaped the reality. Right? We don't exist in a vacuum. We don't exist in a bubble, and these things matter. So when we're thinking about our research, when we're thinking about our scholarship, when we're talking about people who are from different identities, we have to take into account how have these collective incidences affected them or impacted them? And if not, how do we bring awareness to the work, right? Other things that are important for us to recognize is that there are 3 simple truths that exist in our so-called mental health system. And I really do say that because me, as an addiction psychiatrist who tried to engage in the mental health system for myself and for others, it's been atrocious, right? So our current system is not only racist and classist and sexist, all of those things, right? But also it's not working for everyone. And how do we build a system and how do we conduct research that impacts systems that can indeed make it so that the least amongst us is able to benefit, that will benefit all? And then finally, right, so the system is racist, classist, and sexist. It's not working for everybody. But finally, if we want better outcomes, we have to do things differently, right? We cannot just continue to do as we are. All right, UCSF, we are in a liberated space. What does that mean? Is I actually am not concerned if you're comfortable, right? I'm a Black woman in academia. I'm usually not comfortable, although now I'm learning to walk in my skin. But the point is, it's okay if we are having some really spirited discussion for us to learn from one another. Our intent is really to move along a spectrum so that we can do better, right? When we know better, we do better, but we might not always be comfortable, and that's okay. I really think sometimes intention that allows for growth. So I'm hoping today that we can have some discussion. Ask me, Dr. Jordan, what do you think about this? What do you think? How do we move forward in terms of health equity? And in my part of the circle, I'm really focused on making sure we have better access to care for racial and ethnic minoritized people who use drugs. Okay, so you all know, and I just got these updated numbers from SAMHSA that we're dealing with a big problem. 46.3 million people in the US have a substance use disorder. More than 106,000 people died in the US from a drug overdose death. We did see a blip last year, 79,000, but that is still at an all-time high, but we did see a slight decrease in 2022 from 2021, and nearly 130 people die every day from an opioid overdose, which is abominable, especially when we have medication that we know can cut that down by 80%, and we also have access to naloxone that even when people have accidental death, we can reverse it. So that's unacceptable. Also, I want you guys to understand that as we know in this country and globally, that racial and ethnic minoritized populations have worsening substance use outcomes right in the midst of this drug overdose pandemic, but also this has been exacerbated by COVID. Another thing that I want you guys to take away is it's racism, not race. That accounts for this. It has nothing to do with how you were socialized or the processes, the groups that we call someone. We racialize different people. Racism, not race, is account for these differences. And no one can argue me differently, although we'll have some spirited discussion. Okay, so the thing is, if we know that it's racism, not race, if we know that racial and ethnic minoritized populations have worsening substance use outcomes, why does this remain overlooked by academia, public health, law enforcement, et cetera, et cetera? And what do I mean by that? We continue to have really restrictive methadone policies. We continue to have decreased medication for addiction treatment initiation. We make it extremely hard for people to get access to their medication. We insist on people going to things like AA, which I appreciate that AA, Alcoholics Anonymous, has helped many people, but we also have to recognize that AA was founded by two white men, Bill Wilson and Dr. Robert Smith, who centered whiteness in their values, which is okay. But if there are other people who don't identify or are racialized differently, they should be able to choose from another set of options that are indeed evidence informed. And in spite of all this, the NIH continues, right, to have discriminatory practices in terms of who gets funded to do the research. And that's important because we know that racial and ethnic minoritized researchers are more likely to do research that impacts racial and ethnic minoritized population. So I just want you all to see at different parts of the system, these are all the reasons why we have health disparities. It's not the people who are racialized as different groups. And so when you're thinking about, okay, Dr. Jordan, don't depress me, it's beautiful in San Francisco. What do I want you to do is I want you to have access to the knowledge. So you say, okay, what part of the system am I going to impact and intervene on? And I'll share the part of the systems that we're doing in JWC, but you have to know what's going on, right? You can't blindly believe that the system is working for everybody. It's not, right? That's how we end up with someone like Ralph Yarl, 16-year-old, that just goes, picks up his siblings and gets shot through the door, right? It's not the same for everybody. Okay. This is just data. This is actually from Tori Calgar. She is a Harvard PhD graduate student, and she looked at the data in terms of, in different states, what are the racial differences in terms of opioid overdose deaths. And I'm just pointing out, and the most recent data we had was from 2018, is that in 27 states in the District of Columbia, there were actually higher overdose deaths amongst persons of color compared to white population. This is important because I think a lot of times, which is why I always do the land acknowledgement, we actually totally erase Indigenous people from this overdose altogether, even though they have been the most impacted, right, by overdose deaths. So showing people the states where they have the increased overdose rates, but also understanding that Black people as well are now outpacing white people in terms of drug overdose deaths. Why is this important? Because I still work with Black patients who have no idea that they're even a part of this epidemic because they don't know that heroin or fentanyl is an opioid, right? They just think about Oxycontin pills because the mainstream media has really shaped this and continues to shape this as a white issue. It's an issue that's impacting all of us. Also, this is work by Deborah Furholden. We actually just recruited her to NYU. I'm so happy. Hashtag Cite Black Women. She's a Black woman, and she was able to publish an addiction showing that Black Americans now outpace white people in opioid-involved overdose deaths. Finally, just showing you guys that Black and Indigenous people had the highest rate of overdose deaths in 2020. And they continue to be erased from the general conversation. So why, when I read the New Yorker or the Times and the New York Times, I continue to see people who are from the majority population featured? Where is the Indigenous folks? Why aren't we talking about Camilla Venner's work and working with Indigenous men that they are more likely to accept buprenorphine when they're in communal settings as opposed to going to a doctor one-on-one? How are we centering those types of treatment options? Why are they totally erased? Racism, not race, is the reason for health disparities. Okay, so now how am I doing? I think I'm doing good, guys. I'm gonna stop at 9:20 so we can have some discussion, but I want to talk about some of the factors that really exist that are leading to some of the issues that I'm discussing, and then I'll pivot around 9 o'clock to what we're doing in my lab. So when we look at and we dig a little deeper beyond the surface, what are the reasons that impact treatment initiation and access amongst racial and ethnic minoritized people? Because a lot of times the narrative is they don't want help, they have distrust. If I hear one more time about the daggone Tuskegee experiment, I'm like, okay, y'all, right? There's people born now that have no idea what Tuskegee is. So like, I get it, yes, and, right? So we have to really start to have a more nuanced conversation about what's happening in terms of why people are not initiating and engaging in treatment. Can we reflect internally? Can we dare to say they don't want what we got? Because what we got is not affirming of who they are, right? I'll tell you, one of the things that I love to do is work with addiction fellows. And one of the things that we did with the fellows is we did a walkthrough where they had to take on the identity of someone who had a substance use disorder and try to engage with the system. They were treated so badly, just over the phone. And then when one of them actually had to go to a medical withdrawal management, which is what most people call detox, it was so terrible. It smelled. You could actually see lice. This is what? Of course people will be on the street. What are you talking about? And I'm just talking about people who have a substance use disorder. Forget all the other minoritized identities, right? So really thinking about how can we transform and conduct research in a way that is more affirming of different realities. Okay, so I'm pontificating, that was not on the slide, but the things that we have to really understand is how the war on drugs, how is that relevant to what we're seeing now? How do the social determinants of health? I think everyone understands that, but how do the inequities contribute to what we're seeing now? And then really thinking about this concept of othering or stigma, right? Stigma really being social death and how just having a different identity can relate to poor health outcomes. And then we've talked about racism. So these are like 4 major areas, and you can really figure out, okay, how do I focus on either one of these to understand what we're dealing with in addiction? I love this slide. This is again by Amanda Lattimore, hashtag Cite Black Women. She is a wonderful scholar that does a lot of work in understanding the epidemiological factors of health inequity and addiction. I'm going to take you through. On the x-axis is the years from 1970 all the way up to 2019. On the y-axis is the number of overdose deaths. X is horizontal, Y is vertical. What I want you guys to appreciate is this green line that's going through the screen, if you know nothing, I just want you guys to know that that is the number of deaths that have occurred during the war on drugs. So you can see that all of the money that has been poured into really handling drugs and keeping people safe, it's not working, right? The line keeps going up. It has not flattened out. And the bars, the pale like peach, that's the sale and manufacturer of substances. So you can see that most people are actually who get arrested are not selling them, that most people actually are possessing substances. That's the light blue, okay? Because a lot of times I think people are like, we have to go after the drug dealers. We have to lock them up. But you see, most people are actually using or actually have them on their persons, right? And then at the top are just the type of substance that was at the majority at that time. So in the early 70s, it was heroin, then in the 80s, cocaine, then opioids in the 2000s, and now we're dealing with multiple substances. And then in the different years, you're just seeing what was the predominant drug policy. What I want you guys to understand is that in 1971, Nixon declared the war on drugs. He used that as a way to run as his political platform to run for the presidency. He specifically, and I'll include a quote from one of his top 8 at the time, said, I really want to target Black people and people who use drugs so I can be seen as tough on crime, right? Have an enemy, and then use that as a way to elevate and get elected. It was successful. In terms of getting him elected, it didn't help in terms of getting people the treatment that they needed, right? Or treating addiction as a medical disease. The other thing that's important to know that a lot of folks don't know is that in 1986 and 88, during the Anti-Drug Abuse Act, Reagan actually doubled down on the legacy that was set from Nixon and the war on drugs. And actually, that led to discriminatory practices where you could have 1 gram to 100 grams of powder cocaine. If you had 1 gram of crack cocaine versus 100 grams of powder cocaine, you would get the same sentence. So if you look at the US prison population to this day, and you see, look, right when this policy was enacted in 1986, you see a huge uptick in the amount of people that have gone to prison. And as you can imagine, most of them are Black men, Latino men, secondly, Black women, and Latina women. This is not happenstance. This is our history. So we can't talk about then, why aren't people accessing treatment? A lot of them were still in jail, or their grandparents or their great-grandparents were in jail, right? And they cannot engage in what we call citizenship. So we'll talk about that in one of the research projects, why we focus on citizenship as a way to recovery. Citizenship, being a citizen in the community. All right, so John Ehrlichman, who was an aide to Nixon, he said, was the war on drugs ever about drugs? You want to know what this was really all about? The Nixon campaign in 1968 and the Nixon White House after that had 2 enemies. The anti-war left, this was the Vietnam War, and Black people. You understand what I'm saying? We knew we couldn't make it illegal to be either against the war or Black, but by getting the public to associate the hippies with marijuana and Blacks with heroin, and then criminalizing them both heavily, we could disrupt their communities. We could arrest their leaders, right? Black Lives Matter, raid their homes, no-knock warrant policies, break up their meetings, and vilify them night after night on the evening news. Did we know we were lying about the drugs? Of course we did. Looking back to understand how to forge the future, we have to make amends, guys. And there's an attack right now so that people don't even understand American history, so they don't know how we got here. Why am I spending time on this? Because we know when people are involved in the carceral system, that it has an impact on how they are able to live their life, the quality of life. So if you have a felony or even a misdemeanor, depending on what state, it affects what jobs you can get. It affects where you can live. Where you live affects what type of access to food you have. transportation, if you can even participate civically, on and on and on. So one of the things that we're doing in the integrated harm reduction intervention that I'll talk about is part of the intervention is removing felony charges and misdemeanors and working with legal partners so that people can have a chance to even engage in recovery. Like, yes, I want people to be on buprenorphine, but I also want them to be able to vote and actually have some place to live, right? So expanding, how are we thinking about the social conditions, modern day colonialism, and how are we interacting so that we're able to bring about health equity? And are our medical schools and our other departments really teaching this in a way that our leaders are going to be adequately prepared? I say no. There are some places that are doing it well, but I think we need more of it. Okay. I love this. I just love the little person at the iceberg. That's a racial and ethnic minoritized person with a substance use disorder. But I want you all to appreciate is that if we continue to just focus on the person alone, we're not going to move forward, right? We're going to continue to have these worsening outcomes. We're going to continue to be where we are 15 years from now. So really looking below the surface. How are we using the social vulnerability tool? That's something that I use in the clinic. I teach all of the trainees. How are we integrating that into our treatment planning so that we're able to move this person away from the iceberg and get them on their way? I also think we have to really dig a little deeper into this concept of othering. And if we look at what it means to other, it just says to view or treat a person or group of people different than yourself. So if this red person is like on the outskirts of all the folks that are Black, and really thinking about how does that lead to limited resources and poor outcomes for people, right? And it's not always just racism is to treat people differently based on their group classification, but sometimes it's just having identity of someone with a substance use disorder. We don't want them there. They can't be in the waiting room, right? Oh, they have to make their appointment, or they have to come every single day to get their medication, or we have to check their urine. Oh, we have to observe it. Guess what? In the clinic that I work in, I don't check urines. The only time I check urines is when the insurance says, Dr. Jordan, you have to check urine. I have one of the best outcomes for my patient. Why do we treat people differently based on how they are classified, right? Othering has also led to not only people feeling less than the majority population, which in this country is white people, but also I told you about, and I encourage you all to look at some of the references that I have here, less funding for people who are not white. And this was shown in Science in 2011, Science Advances in 2019, and a JAMA article that just came out that said if people have at least 3 NIH-funded grants at the R01 level or above, they're more likely to be what? You can tell me. What do you think? 3 NIH grants. What is the prototype of that person? What do you think? White male. Right? All right. So understanding how we got here is important, but what do we do? And I just want to go briefly through this because I want to get to what can be done. But I love, again, Kamara Jones, hashtag Cite Black Women. I love her article on the levels of racism, a theoretic framework. This has totally revolutionized even how I teach racism, but how I intervene at different levels. So we have to intervene, yes, at the institutionalized level, but also at the personally mediated level and also internalized level. So personally mediated, that means that there's differential assumptions about the abilities, motives, intents of others based on race. So this is an example is physician disrespect. What do I mean by physician disrespect? Anybody in the audience? Anybody? except Christina and Lucy. Yeah, yeah. Yeah, what does that mean when I say physician disrespect? Okay.
Take mental health providers where we're supposed to have empathy, compassion, observation, and communication as our tool. And so many of us may have a level of racism that is not virulent hatred, but is a kind of like lesser compassion, lesser empathy. So she wrote a book called The Suffering Will Not Be Televised. And it sort of talks about how across medicine, across law, across so many agencies, you really see this over and over sentimentalization of white people that are suffering, and like almost like, oh, Black people should suffer. So I think that's a very big pillar of what we're dealing with.
Yeah, spot on. Thank you for that. And I will add that to my reading list, the suffering. Yeah, the suffering will not be televised, but exactly right. The point is that there's been a lot of scholarship that has shown, regardless of what group that you identify or racialize as, that people who are not white are less likely to actually spend time with physicians. They have less actual total time, right? And that the risks, benefits, and side effect profiles of different interventions are less likely to be discussed if you're not white, right? And so it's not always so overt, like down with the Latinx people, right? But sometimes it's just the ways in which you engage, and patients feel that. And what I am proposing is if you are multiply minoritized, right? The further you get away from that ideal identity, the more you're experiencing that. So when I'm taking care of a transgender Black woman with schizophrenia and cocaine use disorder, the way I show up for her has to be the same as I show up for Dr. State, right? And what do we have in place to ensure? Because we can't just rely on the goodness of ourselves, because we know we're all socialized in the system. And what I'm saying is that we not have to teach it, but we also have to grade folks on it, evaluate, use tools like the social vulnerability tool to make sure that we're doing that, right? Okay. So I promise I didn't come here to depress you guys, and I have 20 minutes to turn it around. So what can be done? And I am an eternal optimist, right? I have to be. I mean, I don't have to be, but I was raised that way and really thinking about the community that birthed me and got me to where I am. Okay, so never doubt that a small group of thoughtful, committed citizens can change the world. Indeed, that is the only thing that ever has. So I was really encouraged by the dinner that I went to last night, and met an amazing intern that actually came out, and he talked about all of the advocacy that he was doing. I won't put you on Front Street, but he talked a lot about the advocacy that he was doing because of the discriminatory treatment that he saw with patients, mostly who were Black and brown. And so what I'm saying is that you can't just be resigned to like, this is the way it is. That's it. I just got to keep on doing what I'm doing. No, challenge the system in your own way. Really start to think about, how can I do an assessment of my research or my treatment culture to see what are the ways in which I can improve? How can I bring other folks into it? Okay, so one of the really lovely cultures that I think, lovely concepts that I think is really important is really to focus on structural competency. And again, hashtag Cite Black Women. This is Helena Hansen's work and Jonathan Metzl's work, really thinking about understanding the importance of structural competency next to cultural competency. So we used to think that we just have to focus on the patient and the provider dynamic. That is important. But what structural competency asks us to do is to shift the focus above that patient-provider dynamic, but really think about ways in which segregation, institutionalized racism, personally mediated racism, media, and all that impact the decision-making of the patient. And how can you not become a social worker, but how can you, or I love social workers, how can you form relationships with community organizations that are already doing this work to say, all right, I've done my structural vulnerability tool. I see that they're experiencing discrimination in their housing, that they are illiterate. How can I work with existing organizations that are already dealing with discriminatory practices to link my patient into that dynamic so that they can have better outcomes, right? And work together in a medical model. Also, what's important in addition to structural competency is we have to be careful of our language. Language matters. And this is a paper that was published by really some of my supervisors, addiction specialists in the field, where they were able to show that how you describe a patient in the chart or even refer to them actually is linked to poor outcomes. So we can't use things like addict, abuse, addicted baby, binge, relapse, but really using more patient-centered language. And I always say, call people in. You don't have to call people out. When people ask me for consults, they'll say, oh, I have this 46-year-old addict, And I'll say, oh, can I do a call-in? You mean somebody with a substance use disorder who right? Really being able to have a deliberate attention put on language, because that's propagated in the chart. And before somebody even sees a patient, what they read about them already starts to influence how they're going to treat them. Okay. Another thing that we're learning to do more and more in the Jordan Wellness Collaborative is really to pay experts in the field from the community, right? So voices from people who use drugs, that's PWT, and substance use disorders must be included in the narrative when we're thinking about solutions. So now when I'm thinking about research assistants and building my team and all that, I've also added community health reps who are actually using or in recovery from using drugs, and they have a expertise that I don't have. I don't know what it is to be strung out on any type of substance. I don't know what it is to be homeless. They do, right? And we're able to think of different ways, even ask questions and implement interventions in the way that I would have never thought about. So really thinking about how can we include people, not just as a community advisory board, but actually pay people to be part of our research enterprises. Also thinking about how our health programming must meet the needs of people with substance use disorders by removing current and historic barriers to health. So taking a inventory of your space. What is on the walls? What does it look like? Are all people from the majority population? Like I walk into spaces and I'm like, oh, this is not for me, although this is a beautiful space. But really thinking about, is everybody on the wall white? Is everything in English? Are there anybody that looks like me that's working there? Really opening clinic open hours and not having, it really upsets me. And the people who work with me have had to learn, yes, I'm going to see the patient. I don't care if they come at 1, 1:30, 2, 2:45. I have open clinic 1 to 5. And it's a shared understanding because I understand that the people that I'm dealing with have to take the buses. The trains are not working. Sometimes the trains are gross. I was just talking to Carolyn and Matt about this, right? So as long as they show up, they're going to be seen. I'm not going to have them wait to see a social worker first before they have to see me. That doesn't make any sense. So really thinking about our practices and how can we remove barriers to make it easier. Okay, I have 15 minutes because I'm going to stop. No, I have about 10 minutes. I'm going to stop at 9:25, Dr. Mangurian. I want to talk about community-based participatory research. This is the type of research that I do in the Jordan Wellness Collaborative. We do. It's a collective consortium of folks that are equitably involved in the research process, right? So it's myself as the PI, then we have researchers, and we have key stakeholders, we have mayors, everybody's in the jam at the lab meeting, right? And so what is the continuum of the work that we're doing? We want to move along the spectrum so that we're not just doing research on communities or even research in communities, but really doing research with communities. So there's not a notice of funding opportunity or a request for application that I apply to unless I have already discussed it with the community partners. And sometimes I discuss it with the community partners first, then go to see what is the funding arrangement that is best for this, right? So not kind of outfitting research once you already have your idea and it's like, this is what I want to do. Can you help me get 20 people? No. What is the issue that you're dealing with and how can we find resources to address those issues? All right, so starting with the why, this is a poem that was adapted by Imani Harrington. She is someone who is living in recovery from substance use disorder and also HIV. She says, we need you, our brothers, our sisters, our people. Help us reaffirm ourselves in loving ourselves. Hold us when we can't stand, because soles of shoes have traveled our backs for so long. We need you, our brothers, our sisters, our people. Every single lab meeting, we start by really putting in the space what we're dealing with, looking back to understand how to move forward. I can't just show up when Ralph Yarrow was shot. I can't just show up after the insurrection and just continue on. How are you doing? How are we taking care of ourselves? The work is important, but how are we going to address the real trauma that is happening, right? So we show up with a poem, an inspirational quote, whatever we need to put in the space. I encourage you all to start to cultivate these types of environments that will allow people to do the work and engage in a real way. So there's 3 NIH-funded projects. I just wanted to talk briefly about them. Invite me back for a data-heavy presentation. I'd love to do that. But really thinking about the first one, which is providing substance use treatment, really alcohol treatment in Black churches. The pilot project, which is now turned into our R01, started in New Haven. I'm just showing you that the man on the left is the pastor of the church, extremely progressive, was happy for us to have the space, happy to have quote unquote addicts, but people with alcohol use disorder come into the church for treatment. The second is the mayor of New Haven. So I let him know you are going to have every single Black person with an alcohol use disorder in the streets. So I need your protection. I don't want the cops there because when Black people gather, they automatically think it's something wrong. So I had the participation of the mayor to say, listen, I'm expecting about 400 Black people and it's okay. Please tell the cops to chill. We were able to do that. And then those are the 2 research assistants. They are both people with living experience and recovery from substance use disorders who actually work on the trial. So I'm just showing you all how we approached it. And we were able to successfully treat people who had severe substance use disorder. This is just showing that most of the sample, 53.8, actually met criteria for a severe substance use disorder according to DSM-5. And then just showing you how we actually went through the spiritual component. So they come in, they get treatment, they do the evidence-informed treatment, et cetera. But there is this spiritual session that's conducted by church-based health advisors where people are able to bring in like praise and worship, things from their spiritual identities into the setting. And so I'm just showing that in a short amount of time, 8 weeks, we were able to see a significant reduction in substance use, which is awesome. So that is the work that really led to this larger R01, where we're actually comparing Black adults with substance use disorders, that's on the left, in the church setting, with treatment as usual and addiction clinics. And we think, we stop next year, we think that we're going to have better initiation and retention of people with alcohol use disorder in the Black church than going to traditional substance use centers. And we also think that we're going to get a significant reduction in use in the church as compared to treatment as usual. Let's see. I'm excited about that. The next project in collaboration with Sherelle Bellamy, Dr. Sherelle Bellamy. She's actually a full professor. I'm so proud of her at Yale, who is in recovery from cocaine use disorder and also opioid use disorder. It's important for me to say that because I want people to see what recovery looks like, right? Representation matters. But what we're doing in Imani is we're actually providing medication for addiction treatment in Black and Latinx churches. And we do it all through telehealth, because the folks said to us, we don't want the doctors in our space, but we do want to be able to access treatment. So we have all Black and Latinx addiction psychiatry fellows that actually use telehealth to provide the treatment into the church. And so what we're doing in the R01, I'll get to it, is we're comparing medication for addiction treatment in the Black and Latinx church via telehealth versus medication for addiction treatment in the community. So we're providing medication for opioid use disorder, alcohol use disorder, and also tobacco use disorder. What are the actual components of Imani? Imani means faith in Swahili, and that was a term that was given to the project by the community. But it's 6 months worth of classes. And we focus on what I was saying, the citizenship process. So what are the roles, responsibilities, relationships, resources, and rights necessary to establish citizenship? And this is based on an evidence-based module that was developed at Yale that showed that for people with serious mental illness, when they just engaged in these classes, they were actually able to reduce their substance use. So not even with medication, but just understanding what does it mean to be a citizen in the community and taking instruction in that and showing up week after week, they were able to reduce their substance use. So we said, can we combine that model, offer it in the church setting with people who look like them, and then for people who opt in to wanting medication? Not everybody has to opt in, but for people who opt into medication, they're either randomized to medication for addiction treatment in the church via telehealth or medication for addiction treatment in the community. And we believe that the people who receive medication for addiction treatment in the church will do better than those who go out to the community. So that is what we're actively doing now. And here I'm just showing you all the types of medications that we offer. We're able to offer everything except methadone, because methadone is not available right now outside of opioid treatment programs, but we're very active in really changing that, especially for research purposes, so that we're able to offer it to people with opioid use disorder. So stay tuned for that. Okay, the last thing that I want to talk about is, because we just got this funded, is this integrated harm reduction intervention. I'm so excited about this. Basically, we are working with Black and Latinx people who use drugs, who are not interested to stop using drugs. And we just want to say, can we reduce overdose deaths? And so we're working with one of the only all Latinx run harm reduction organizations in the United States, St. Anne's Corner for Harm Reduction. And we're going to compare the services that they already provide to what we're calling our integrated harm reduction intervention, where we are actually partnering with legal, mental health, and what's the last one, guys? Legal, mental health, and substance use treatment. And we think that having access to all of these things will work out better in terms of reducing death than services as usual. So we'll see. But we have it in two places. We're working both in New Haven with a Black-run harm reduction organization and then in Latinx community. So we'll talk more about that. I just wanted you all to see the team. I'm really excited that we only have one white man on our team. I love white men, but it is just full of color, right? And representation from all different types of folks. And then I'll end with this slide. When thinking about health equity and addiction, I want people to understand it's not just about anti-racism. Like, I get it, but health equity goes beyond anti-racism. It's not just the absence of discrimination and inequities, but the presence of deliberate systems and supports to achieve and sustain health equity through proactive and preventative measures. So anti-racism is just the beginning, but what are we going to put in place to ensure that people have access to all? All right. Thank you to all. Thank you to all the people I work with. And the most important is I'm a fur baby. I'm a fur mama. Those are my fur babies. And I'm an auntie. So those are the people that I love and allow me to do the work. So thank you so much. I know I went over, but question.
Excellent. There's outstanding talk. I think that I see somebody up there, maybe
Yeah.
Dr. Tulashans.
Yeah.
While they're getting to her, there's been one question on the Zoom that got a lot of attention. So people loved your approach to the open clinic hours.
Yeah.
Dr. Stewart, who's our vice chair for child psychology, wanted to know your thoughts of rethinking the classic therapy hour to move into an open clinic model for brief and targeted interventions and increase access and flexibility to responsibly respond to social determinants of health.
My answer is yes. Truly, I really do mean that. But I think if I can just add a little bit is providing the framing and the context. So you have to get people on board with your vision. You can't just come in and like, I'm changing everything. What y'all doing is not working. No, really thinking about how are you going to have a shared vision. And so everybody, most people, you don't need everybody, but most people will be on board. And really thinking strategically. I always have a strategic map when I think about changing systems. I'm really not kidding. Who are my allies? Who do I know get it? Who do I need to convince a little bit more? And what is their currency? Is it data? What do they care about? Do they care about no-show rates? Who do I need to get involved to see that vision? So the answer is yes. I do think that is a way to really democratize access to psychotherapeutic interventions, but also thinking about not how is it going to land on the patient? Do you have patient stakeholders that can understand the vision and get people on board and maybe present to the CEO or whatever? But also, how can you have those conversations ahead of time so that you can I always say, just give me a pilot. Let me do, I love pilots. Let me do 30 days. And then the proof is always in the pudding. When you start to see people showing up, when you have to see decreased attrition rates, right? When you have improved quality measures, those are the things that count. So yes, and have a strategy. Yeah.
Awesome. Hi, thank you so much for coming to UCSF.
Yes, I'm happy to be here.
So good to see you. Yeah. I am wondering,
yes,
how or what kind of guidance you might give to trainees, research assistants, junior, early career folks who are getting into this field from the perspective of what we hear in a lot of our work in the juvenile legal and child welfare system and trying to do these structural interventions. How do we do this work without also being complicit with the system that's being oppressive?
Yeah.
And trying to keep up, right, the support, the motivation, the advocacy for those who we desperately need in this field to continue this kind of work. So in research and clinical, and so I'm curious what you would say to that.
Yeah, that's something that I think about all the time in terms of how do I really, in that very first slide, not to be implicit in the colonialism of others, right? The political control and political co-opting political will of others. I think the most important thing truly is to find your people, right? So really being surrounded, which is why, and I'm so happy to have lovely people around me, but really thinking about if the folks are not there, how do I create a system? So the REACH program, Recognizing and Eliminating Disparities in Addiction Through Culturally Informed Healthcare, is a program that we started because we wanted progressively minded addiction specialists who were critical of the system. And because I didn't have a lot of addiction specialists that were already in existence, I said, okay, I'm going to create that system to be able to train the colleagues that I want. And so really thinking about how do you engage with folks who are really wanting to do things differently, surrounding yourself with them, but also realizing that Rome wasn't built overnight, and thinking about what are the small wins and being able to celebrate, right? So I was very happy. Everybody knows that I am not pro-police. I'm not. That's Ayana Jordan, right? But I understand that in certain systems, there will be police. So how can I celebrate a small win that I say, can you not escort my patient to the clinical room, right, with me? I understand that you guys have to be at the front, but can we work out a protocol where they're not having police escorted to their clinical rooms? So really figuring out ways that you can work within a system that you might feel is not therapeutic and celebrate those small wins. truly, because that allows you to not get overwhelmed with all the realities that I went through at the beginning of the slide, right? So find your people, they're out there, email them, follow them on Twitter, ask to collaborate with them, but also celebrate the small wins. And I always say the revolution will not be televised. So I love all of the secret meetings, right? How are we planning in the night truly to think about a system that can be more equitable? Yeah.
Excellent. That's the perfect way to end this now. I'm sorry, we're at.
Oh no. Okay. Thank you guys. Thank you.
30, but I just want to say thank you so much, Dr. Jordan. You were incredible and got so many just positive responses all over.
Thank you for having me. And thanks for the mic change. This was much better. Yeah.